Okay, everyone. So we'll be discussing question number 11 of the surgery CMS form 3. I have two previous videos of discussing the last 10 questions of the same CMS form, and those videos are in a longer version. We've had quite a few requests to create short videos explaining single questions in a single video. So personally, I don't recommend that, but since this is in demand, so I am going to try this out, the shorter version videos. So today I'll be looking at this question, which is from electrolyte slash acid base testing for the subject, and this would give you a good concept on what we're trying to achieve, what management should be there, and how should we basically approach these kind of questions, and how I approach this kind of question, and how to extract clues from it so that you could get to the right answer. Okay, so let's begin, and make sure to watch the previous lecture, the previous two videos on this to understand the rest of the 10 questions, and we'll be continuing this form till the very end. So, which of the following is the most appropriate next step in management? This is a management question. 6 hours after sigmoid colectomy and colostomy for perforated diverticulitis, a 62-year-old woman, sorry about that, 62-year-old woman has had a total post-operative urine output of 65 ml. Through a Foley catheter, preoperatively, the patient had a serum urea nitrogen concentration of 45 and a serum creatinine concentration of 2. She has been receiving 0.45% saline at 90 ml per hour since the operation. She is 5 feet 2 inch tall and weighs 60, BMI is 24. Her pulse is 95 and blood pressure is 130 by 90. Her serum electrolyte concentration are within the reference range, and urine specific gravities are 0.028. Which of the following is the next step in management? Okay. First of all, let's look at the values that are given in the question to see if they are normal or uh, what is the derangement in them, if there is any. So the first value that they've given us is post-operative urine volume of 65. Now, if you know that the appropriate or the minimum urine output that an adult should have is 0.5, right? So it's 0.5 ml per kg, kg per hour. So this is the normal, the minimum, I would say, threshold of urine output that the person should have. So lesser than this, then it's going to be oliguria, right? Something that you call as the decreased urine output. So oliguria. Okay. Now, if we were to calculate this woman's normal or the minimum urine output, we would say that 0.5 should be multiplied by 65, right? So this would be like 22.5, 33 years or something like that. So whatever this would be, I would say, around 30 ml per hour. Estimating it as if you're in the exam room, you don't really need exact figures. So this would be 30, right? 30 per hour. And she has had a total of 65 ml for 6 hours. Otherwise, just showing you that this is oliguria. This is decreased urine output. So this is the first problem that we have. This is the first problem. Okay. And preoperatively, the patient have had a serum urea nitrogen concentration of 45, and a serum creatinine concentration of 2. So you already see the problem with that also, right? So if you take a BUN creatinine ratio of 45 divided by 2, you don't really need to do it, but Whatever this would be is 22.5. Exactly, this would be more than 20. This shows that the woman already had perirenal azotemia before uh, her operation started. And now we have another value, which is uh, the urine specific gravity. And if you know the normal value of this as well, so this is from 1 point 0 to 1.03. So the more nearer the value is to 1, the more dilute the urine is, and the more nearer the value is to 1.03, the concentrated the urine is. So you can see that this is 1.028. So this is nearer to 1.03, which means this is concentrated urine. So what is this showing us? What is the whole picture of this is showing us is that the woman is having oliguria. She had a perineal azotemia before her operation started, and now she has oliguria and she has concentrated urine. So this is a classic case of dehydration or depletion of the extravascular volume. So now what we do have to do in the management. So keep in mind what they're asking. They're asking the management. Measurement of creatinine clearance, wrong answer, because this has no value. I mean, we already know that she had a problem and her creatinine concentration was 2. So this creatinine concentration of 2 means that she's already lost like 90% of her renal function. So what good would we do by measuring her creatinine clearance? She's already in the end stage renal disease territory. So this would have no use. This is wrong. Intravenous myelography is wrong. And with that, renal perfusion scan is also wrong because, first of all, they're not asking us imaging, they're asking us management. And even if we don't differentiate between the words, uh, this is usually done in an obstructive pathology, right? Or any vascular pathology. So you're going to check a renal infarct from renal perfusion scan. This is not, both of them are not needed right now. Administration of intravenous fluids to replace insensible fluid loss is the wrong answer. Because when do you ever give IV fluids to replace insensible fluid losses? Insensible fluid losses means that the loss of fluid from your breathing, from your skin, which you are not usually conscious about, but there are very minimum non-critical fluid losses. So something considered non-critical, why would you ever give IV fluids for it? I mean, this is not evidence-based, and this is just a very non-practical, wrong answer, wrong way of management. So this is never going to be done. Okay. Administer IV fluids to replace urine output. Only this is again, this doesn't really make sense because you first of all don't need to replace it. You need to maintain the urine output. So you need to maintain it, right? You need to maintain the urine output. You don't need to replace it. And first of all, and second, urine output doesn't really show the clear picture of how much fluid is depleted in the body. This just gives us a sign that the fluid is depleted. So we can never practically just replace the urine output only. We have to maintain it to a normal level to understand that now body has normal intravascular volume and now it's producing normal urine. So that's how things go. That's the concept. This is the correct answer, D. Uh, for the reason that you are giving 0.9% saline in every case of dehydration or depletion of extravascular volume, you give an isotonic fluid. So over here, I'll just write ISO. So over here, she's receiving 0.45% saline, which is a hypotonic solution. This is not going to do her good, all right? This might even lead to other problems. But whenever there's a question of dehydration or depletion of extravascular volume, you go for the isotonic solution only. Now, is this right? Rapid administration doesn't really matter because this part is correct, okay? And you don't need to second guess yourself. You need to understand that isotonic solution is where it's at. This is the management, 3 to 2. For every dehydration case, there is. For a depletion of extravascular volume case, there is. So this is the correct answer. I have also some notes here that I've written, and you can read them if you want to, but these are all the same things that we discussed. Okay. And why the other options are incorrect? Because again, this is not useful in the acute management. Again, these are not practical in this case scenario. A replace insensible is inadequate in a patient with clear evidence of hypovolemia, so that's really not evidence based. And the replace urine output is misguided. In post-operative patients with oliguria, the initial step is to assess volume status and administer isotonic fluids if hypovolemia is suspected. Diagnostic testing should be deferred until after adequate fluid trial. So you need to remember this, guys. This is the most important takeaway.